Hello friends, welcome back to the channel. My name is Jen Hamilton and I hope to just be your best friend who is also a labor and delivery nurse who can kind of help you through these things that you might have questions about, because not everybody knows about all this labor and birth stuff, and that is a-okay. So I hope to give you some advice, some friend times, and some evidence-based stuff. And if that's something that you're interested in, please like and subscribe, and let's get into this. I was thinking, one of my favorite things is reading your birth plans. It helps me so tremendously to be able to find out what is important to you and why it is important to you so that I can advocate for you better. Let's go over some birth plans that I found on the internet and see what the vibes are, and I can kind of give you some extra info on the things that we see. So this is a sample hospital birth plan. The top of it says, "Thank you for helping us birth our child. If any of these requests could be granted, we would be ever so grateful. We do, however, understand that emergencies happen and complications arise, so all of these may not be possible." That is very, very kind and sweet. I love the beginning, understanding that these are things that we would really like to happen. We understand that things are not always possible, but work with us, basically. There may be things that come up, but as your nurse, I'm going to do as much as I possibly can to follow the birth plan exactly how it is. We are a hypnobirthing family. Hypnobirthing can work fantastic. Hypnobirthing is a way of coping through labor that allows you to kind of ride labor in a positive, calm way. I'm sure that there's a much better way of explaining that, but it's a mindset, it's a frame of mind, it's kind of hypnotizing yourself to be able to deal with the struggle of labor. If I have someone who is going unmedicated, I also don't ask them if they're hurting, because duh, they are. When you meet yourself in labor, you will know whether hypnobirthing is going to be helpful for you or not. I've had patients who meet themselves in labor and they're like, I can do this, and this is very helpful to me. I have had people who meet themselves in labor and decide that it is not helping in the way that they hoped. It's all about having grace for yourself and understanding that this is a big deal. And so if it's something that isn't working for you, don't panic. There are other things that are available to you, but having that grace for yourself. Please do not offer pain meds. Let me ask for them, and do not assess my pain levels or discuss or ask about pain. I said that. That's so funny. So that is something that I do for my patients, just to make sure that I'm not making them think about their pain more than they already are. Please keep the room warm and dimly lit if possible. I love this. It's good for babies also whenever they come out. I will say that there are people that have put this on their birth plan and then ask for me to crank up the air because it gets warm. When you're in labor, you are working hard and you can work up a sweat. So asking for the room to be warm may or may not be something that you like when you meet yourself in labor. Dimly lit. I love this. Some hospitals, like my hospital, we have different areas of light in the room. So we can put on a small light, we can put on a big light. There are times where a big light would be necessary, and that would be during procedures. You know what I'm saying? If you need an IV started, you do not want the room to be dimly lit. Or if you're getting an epidural, you do not want the room to be dimly lit. I love keeping the lights low when we're chilling. After a 20-minute NST, which stands for non-stress test, it's basically just putting your baby on the monitor and monitoring the contractions and your baby's heart rate to make sure that everybody's good. Please allow intermittent monitoring and permission to walk in the room and bathroom privileges. Intermittent monitoring is fantastic. It's where we're just kind of listening to baby every once in a while, just to make sure that baby's still doing okay. There are people who this will not be a good idea for. This is for very low risk people who are going through spontaneous labor where we don't have to keep a really close eye on baby. But having a 20-minute strip like they're talking about is what we would need in order to say, hey, your baby is doing great. We can take you off the monitor now and we'll recheck again later. Now, if we put your baby on the monitor and your baby is showing signs of distress, this would be something that could change that. We love the walking. Bathroom privileges. Girl, go to the bathroom. You know what I'm saying? You do what you need to do. Please allow me to labor down to crowning. Laboring down means not pushing until you feel the urge to push. The issue that I have with this is that may not happen for you. You could have that urge to push and not be crowning. When I say crowning, I mean your vaginal opening is this big of head. We see your baby's head. That is crowning. Having this as an expectation can really, really set you up for some disappointment if that doesn't happen for you, especially if it's a first baby. It is very normal to push for over an hour, sometimes more, if it is your first baby, even unmedicated. I decline antibiotics from unknown group beta strep status and would like to follow the CDC guidelines for intrapartum unknown GBS, which is no antibiotic risk factors present to delivery before 37 weeks. And she puts like the things in there. Following CDC guidelines for GBS, group beta strep status is fantastic. Group beta strep is a bacteria that can normally and naturally live on about 40% of people's skin, and it is not harmful to us, but it can be passed to your baby and can cause really not great things like GBS sepsis or GBS meningitis. She's saying that if it is unknown whether she has GBS or not, and she doesn't have any extra risk factors, that she doesn't want antibiotics. And that's cool. All of these are conversations that you need to be having with your provider. So you have all of the information that you need to make that decision. Please let us know when we can take photos and if we can take any video footage. Most hospitals are going to have a policy that you can't record the birth. I can't take your phone away. Do you know what I'm saying? Do what you need to do. Talk to your people. I don't know what your policies are. For the birth, please keep lights dim if possible. Love it. I will say that having the lights really, really dim and not having any extra light can be tricky to know some things, like if you begin to bleed or if we're seeing any extra tearing happening or something like that. You might want a little extra light just in the sweet spot, but having the lights low is absolutely fine. Please no students or extra people in the room. Please no shouting, no force pushing, no counting to 10 while pushing. Let me do this on my own. That goes great most of the time. And all of this is just me giving caveats to things. For the friend that I was talking about that was completely dilated for 10 hours, she had this one on her birth plan too. She said, do not coach me in pushing. She had taken many courses during her pregnancy to know how she wanted to push. And the way that she wanted to push was taking a big deep breath and breathing her baby down, which can work great for some people. The trouble was that she pushed for hours and hours and hours and did not move her baby not 1 millimeter. So we changed up the way that we did the pushing and she started to have some progress. So being open to hearing how your pushing is going, if you're making progress, if there are certain ways that you try pushing that are better than others is always fantastic. So if your team starts counting for you and you don't like that, you can absolutely tell them stop. I guarantee you it's just out of habit. Please allow for restitution and refrain from pulling the baby out. Let me push her out. Now, this means that when the baby is coming out, allow the baby to kind of turn in however he or she wants to settle before coming out. They'll move their little heads in there and they'll turn their shoulders to be able to fit how they want to. Sometimes there can be a fear of the baby getting stuck. Like if the baby's head comes out and the rest of it doesn't immediately come out, sometimes providers will like apply a little downward traction to try to get that shoulder out. What she's asking for is instead of like pulling, which I don't feel like a lot of people do. I feel like if they're pulling, it's out of like, something's happening, but to allow her to push baby out. This can be timed with contractions, right? So if baby's head comes out, we can wait for the next contraction and see if mom can push baby out and try that. Please no episiotomy, perineal massage, or perineal ironing. I don't know what perineal ironing is. What is that? Is that bad that I don't know what that is? Perineal ironing. I'm looking at images. Some form of perineal stretching. So this person does not want any messing with down there. They do want warm perineal compresses for down there. So warm compresses is something that can kind of be comforting down below as you're pushing. There are certain midwives that I work with who actually do not like the warm compresses because they feel like it encourages swelling. So I think it's more for comfort, and if it's something that is comforting to you, you can ask for it. If something that's not, you don't have to. Episiotomy is something that should never, ever, ever be done just because, or to prevent tearing, because an episiotomy is a cut that is made in that vaginal tissue in order to make more room. There are certain times an episiotomy would be necessary, and that is if your baby is in severe distress or you are having something called a shoulder dystocia. The shoulder dystocia episiotomy would be to allow the provider's hands to get in there to be able to safely get your baby out. Those are emergencies. The reason that episiotomies are not evidence-based is because if you are cutting tissue, you're making like a straight up and down line, it does not heal nearly as well as a vaginal tear, which it tears like this and then comes back together like this, right? So it is a much stronger healing process whenever you are allowed to tear on your own. Please let me birth in position other than lithotomy, which means on your back, if that is working well. I tell people that your birth position, the position that you birth in, I had a girl one time who told me, she came in, she said, I'm going to deliver on my hands and my knees because that is how I want to deliver. And I said, yeah, girl, we will do that. And then she got to her unmedicated pushing stage and she said, F that. So you are absolutely free to try as many positions as you like. It is going to be something that is a dance between what feels good to you, what your baby tolerates, and what moves your baby. So being able to look at all three of those things is going to be able to help you find the position that is right for you. I would appreciate it if you could put the baby directly on my chest, skin to skin, which should be standard in every hospital. There is no reason, unless your baby needs immediate resuscitation from the NICU team, that your baby should be separated from you at all. And there is some evidence in some hospitals where they're trying to now resuscitate babies skin to skin, which is super cool. But yeah, babies should always be going to skin. Please delay cord clamping until the cord has stopped pulsating. This can take several minutes, so she gets all of her stem cells and blood volume. We'd like to cut the cord. What I do when people ask for extended delayed cord clamping, because delayed cord clamping should be standard in every hospital at this point. In most hospitals, the cord clamping is like a minute, which is kind of like a schmeasly amount of time. So if someone specifically asks for extended delayed cord clamping, what I'll do is I'll let them be the keeper of the cord, right? I'll let them feel what it feels like to have that cord be pulsing. And then they let us know when they feel comfortable with cutting the cord. No erythromycin eye ointment. I do not have gonorrhea or chlamydia. Now, the eye ointment is to prevent infections in babies' eyes from coming out, anything that they could come into contact with. Things like gonorrhea and chlamydia are the ones that are the most scary because they can cause blindness. There are people who feel very confident and comfortable in saying, no, I do not want that. They've been tested in their pregnancy and they know for sure that they don't want that. You get to make your own informed, empowered decisions. It's one of the things that is recommended by the American Academy of Pediatrics. So it's something that's done kind of standard on all babies unless you ask for it not to be done specifically. Please allow the baby to stay skin to skin in my arms rather than the warmer. Absolutely. That should always be done for sure. There are even things that we can do with your baby skin to skin. The only thing that I can't do with your baby being skin to skin is weigh them and give them oxygen. No chemicals on the placenta. I don't know what that would be referring to. I've never seen anybody put anything on a placenta. That's interesting. Do not send it to pathology. We would like to take it home with us. There are times when your provider may recommend sending your placenta to pathology. This is if there's something weird. There's something weird going on, right? Whether you have severe preeclampsia and you get super, super sick, or your placenta comes out and it's got something crazy on it. I've had some patients who have had COVID during their pregnancies and their placentas come out crazy looking. And so those are the ones that we would send to pathology. Now, what that would do is it's kind of like doing an autopsy on your placenta. So it kind of gives you some answers if there's anything that's what was going on with why your baby maybe wasn't tolerating labor or something like that. Now, we don't do that for everybody. I'd say maybe 1 in 10 they would send to pathology, but you do not have to have that happen if that's not something that you want either. The placenta is yours and you can take it home if you want to. If you're going to take it home, please treat it like chicken. If you're going to eat it, you know what I'm saying? Keep it cold. Don't leave it on your counter. Postpartum unit, we would like to request a room with a sofa or a bed that my husband can sleep on. I hope everybody has that. Breastfeeding only. Your hospital should have people that can help you with lactation. Your nurses and rate, they should have lactation consultants who can help you with breastfeeding. Please keep the baby in our room. That should be standard also. We decline a septic workup on the baby for unknown GBS status, meaning like taking blood, like testing baby's blood, as this is not in line with CDC guidelines. We are aware of the signs of infection in the newborn and will monitor for them. She said specifically that this is for unknown group beta strep status, meaning that if they're not sure if they have group beta strep or not, we're not doing this. But if you're positive for group beta strep and did not get antibiotics, your pediatricians would definitely recommend that they watch baby for a little while. I would like to request an early discharge if stable. I love that so much because getting out of the hospital and getting home and back to where you're comfortable is super important. You're welcome to stay longer if you want to, if you want some extra help. But if everyone is fine, if the birth went great, you're great, baby's peed, pooped, eaten, you could be able to get out of that hospital by 24 hours. Now, if you delivered your baby in the middle of the night, they're not going to discharge you in the middle of the night the next night. They'll wait till the next morning. But yeah, get out of there for sure. But yeah, thank you so much for looking over this birth plan with me. I love looking over birth plans, and I think that talking about birth plans is a way that we can also have some extra information to help us make informed and empowered decisions. So please like, subscribe, and I'll catch you on the next one.